Good morning, everyone. So like I was saying, Dr. Misialek has lectured and given lots of didactics at Tufts in the past, but it's been a while, so I'll introduce who he is to you. He is a very active pathologist in our community and serves as Associate Chair of Pathology at Newton Wellesley Hospital in Newton, and is also the Medical Director of the Vernon Cancer Center, Chemistry Laboratory, and point of care testing. As I said, he's a strong advocate of pathology in general, which you can see through his website and also on his Twitter community. And throughout the COVID pandemic, he's really emerged as a prominent figure in the public, appearing on multiple news channels and explaining to us the laboratory testing and using his expertise in that to implement testing in the community and even at schools. He is medically trained at the University of Massachusetts, where he also completed his residency. And I think a portion of that was done also at the University of Florida. And he completed a fellowship. I thought it was actually now beginning to question, was it at the University of Florida or UMass?
Yeah, surgical.
Okay, it's surgical pathology. And I think while his expertise is very vast, there is a little bit of clinical interest in bone and soft tissue and hematopathology, but he really has expertise in all domains of pathology, including cytology, which is why we are very lucky and excited to have a lecture from him today. So thank you again for joining us this morning, and we're excited to hear from you.
Great, thanks so much for the kind introduction, and welcome everybody. Thanks for joining. Cytology, a good topic. Everybody been exposed or rotated through it, at least in some degree?
There are the first years I think have not, but we do have two cytotechnicians online as well, so they are definitely ready to have cytology.
All right, so I'm going to attempt to share this, and let's see, you should all see it now.
Yeah, we have the PowerPoint.
Okay, there we go. All right. So I'm going to talk about things that I've learned here in cytology that are good pearls for you in the real world. So rose pearls is not some sort of rare gemstone, nor is it a type of rose, but ROSE actually stands for Rapid On-Site Evaluation. And this is the cytology equivalent of a frozen section. And it's a great opportunity for pathologists to be proactive and in the spotlight and interact with our clinical colleagues and even at times the patient. When this is how we have it set up here at the hospital. When we get called for a procedure, we have a cart, and on that cart we have a scope. We have dipquick stains up here. Down on this tray here, there are some slide folders, supplies. We carry Cytolite, which is our routine fixative for non-GYN specimens and GYN. RPMI, we carry that in case we are sampling a lymph node. We want to preserve some sample for flow cytometry, molecular, whatnot. We usually carry some formalin. Sometimes these procedures wind up in an FNA and then they proceed on to a biopsy. We have different requisitions, and we can talk about that based on the type of specimen we're collecting and some of the esoteric testing that might be required. This is what we came up with after many years of trying to work on this and capture all the elements. We put the patient sticker here, where we've gone, who's authorized it, the radiologist or surgeon, who's going on it, a little bit of clinical history, and then the sites that we're sampling. And sometimes it can be multiple sites, sometimes it's just one site, the pass number, episode, and these are all driven by billing requirements. We've got the CPT codes over here, and as you'll see, usually if we do an initial, say we're sampling a pancreas and we do a first pass, The first pass you see is an 88, 172, but then subsequent passes are 177. If we were to look at a touch prep or just a brush, it's a different cytology CPT code. Down here, we'll check off what we've collected. If we've collected anything in RPMI that we want processed either into a thin prep, cell block, or for flow. If we've collected anything in cytolite, formalin, for histo, cell block, how many direct smears we've done. Diff quick is what we do right on the spot. We will put some smears in alcohol, bring them back to the lab, and those will get a pap smear, a pap stain, or we could do an H&E as well. This we'll talk about for thyroid specimens, any of the gene classifier tests, and this is a new addition that we just had, and we'll talk about that as well. All right, so thyroid. Let me switch screens once again and jump to a case. I hope you can see this. You guys see that? Okay. All right. So this is a diff quick for a thyroid FNA. A lot of blood. First of all, does anybody know what adequacy should be when we're evaluating on site for thyroid? How many cells do we need? What sort of elements should we be looking for?
6 groups of cells, and each group at least 10 cells.
Perfect. So 6 groups of what kinds of cells?
Follicular cells.
Yeah, perfect. So are these some follicular cells?
I think so. Some of the areas.
Here's a group of follicular cells. And this is San Hong, is that right?
Yes, this is San Hong, yes.
and what year are you?
Oh, I'm 4th year. I'm graduating.
Oh, good. So you can teach us. All right. So 6 groups, 10 cells each. What's also nice to see?
Follicular cells, I mean, there's exception for this rule. If we can make, say, atypical cells, or we can say colloid. These are colloid, yeah. Right? Yeah.
Yeah, so this is what colloid looks like on a diff quick. And colloid, as you know, is what's in the follicles. And on diff quick, it can appear metachromatic, sort of purple or blue like this. It can be thick and clumpy like this, or it can be what we call watery colloid, where the background looks kind of watery versus this hard colloid. And if we see some, I'll point it out to you. But here's some more colloid. So we've got colloid. We saw 3 groups. There's probably some more groups. And what's important about the groups? Well, I guess before we jump to the architecture, let's talk about the cytology of the cells. So in thyroid, nuclear cytology is very important. Normal follicular cells generally have very fine chromatin. You can't really make out a nucleolus. Sometimes maybe a little one there. Cytoplasm is usually fairly abundant. But what are some nuclear features that we might want to look for if we're worried about a cancer or not?
Nuclear clearing?
Yeah. And what would that be an indication of?
PTC?
Yeah. So papillary thyroid. The other common element we often see in these are, what's this cell here?
Macrophages.
Yep, exactly. So macrophages usually have some pigment. When we see them, it's usually a sign that the lesion is partly cystic to some degree. So we're kind of bordering here on not just, my intent was to kind of show you what's important about different organ systems that you might get called on for rapid evaluation for cytology and sort of what you need to know right then. But I'd also like to sort of dive into some of the other things that you'll be working through as you get these slides the next day on your desk. Okay, so we want to make sure there's no nuclear clearing. Inclusions, are inclusions important?
Yeah.
Yeah, I see some nodding. And inclusions would be another feature of papillary thyroid carcinoma. So nuclear clearing, pale nuclei, nuclear inclusions, and what else about the chromatin? You might see a groove. So groove nuclei, clearing. No, don't really see any of that here. All right, so those are kind of things to quickly look for on the cytology front. Now, equally as important in thyroid, not only is the cytology of individual cells, but also the architecture of these groups of cells. And there's two categories of how these cells can group. The follicles can be either microfollicles or macrofollicles. And why is it important to recognize that?
I think for the micro follicles, it's kind of related to neoplasm, and the macro is sort of more towards benign.
Yeah, exactly. So microfollicles are usually an indication of a microfollicular lesion, follicular adenoma. You worry about something neoplastic, whereas macrofollicles are more often a benign lesion. It can be normal thyroid, it can be colloid cyst, colloid nodule, or a macrofollicular lesion that is more often benign than not. And that's something, if we recognize it and it's the predominant pattern on the slide, the case can be signed out as such and favored benign. What kind of groups are we seeing here? This one is good. Oops. One group here. Is this a macro or a micro follicle? And how do we tell the difference?
I think this looks like micro.
Yeah. Good job. So microfollicles usually have some, the cells aren't evenly spaced, they don't look flat. Oftentimes a macrofollicle, they'll be honeycomb with very little overlap. It'll be a big flat sheet. When we start to see three-dimensionality or cells piling up on each other, crowded like this, and a small follicle, microfollicle, when that's the predominant pattern, we're going to get worried. And this is where I start to put things into either a atypical or suspicious or outright positive for follicular neoplasm. And I think every group that I've shown here has been a microfollicle. Let me show you the pap smear on this one. Now on PAP, they're obviously a little better preserved. You can make out that really fine chromatin, delicate cytoplasm. Now that group is a little bit tougher to say it's definitely a microfollicle because it's kind of flat. It could be a piece of a macrofollicle, so you have to be careful. But so far, we haven't really seen big sheets that show overlap. Sometimes a whole follicle can be aspirated and a macrofollicle can be aspirated. I'll show you what that looks like. All right, so for the purposes of a rapid evaluation, this is adequate. So this is actually the fourth pass on this patient. So it took 4 passes to get to adequate here. That's fine. Sometimes you get adequate the first pass. Good rule of thumb is not to just stop after 1 pass, but at least 2 passes, I feel, and potentially 3. So if you're doing this rapid and you're thinking, geez, first of all, it's adequate. I can tell the radiologist or the surgeon who's ever doing it, you've got adequate cells. Also in the back of my mind, I'm thinking about where's this lesion going to fall? Do I get a gut feeling this is benign? Is it outright malignant? I'm not going to tell them that, obviously, but is it something I'm worried about? And if it's something I'm worried about with a microfollicular pattern, what might be a useful test to collect something for that we may end up sending after sign out? Here, I'll go back to.
You mean like the Affirma test?
Sorry?
Like the Affirma test?
Yeah, exactly. And what is that?
I know it's a molecular test that can help further evaluate the possibility of being malignant.
Yeah, exactly. So it's a gene classifier. There's 4 major tests out there. We'll go through briefly each one. But before we do that, let's back up. So this is sort of the Bible for thyroid, the Bethesda system. And these are the major Bethesda categories: non-diagnostic, benign, atypia, or what we call FLUS, follicular lesion of undetermined significance, then a follicular neoplasm or suspicious for follicular. These are the suspicious for malignancies, and these are outright malignant categories. Adequacy, as we discussed, at least 6 groups of benign follicular cells. Macrofollicles, generally there's colloid in the background. It's a monolayered sheet of evenly spaced cells, often can look honeycomb. Sometimes they're 3-dimensional, and I'll show you how that's different from the 3-dimensional microfollicle. And usually you'll see some histiocytes in the background. So if you're doing a rapid, you have a lot of colloid, a lot of histiocytes, that's generally a reassuring feature. Here are some examples of some macro follicles. So flat sheets, they're evenly spaced. We don't really have a lot of overlap of cells. Sometimes, and here's some colloid, sometimes you can aspirate a whole, like a microbiopsy, similar to like in a ECC, how you might pull out a whole like gland tube. Sometimes you can see that. That's not to be confused with a microfollicle. Here's an image right from the Bethesda book. Nuclear overlapping in the form of folded sheets may be observed. So this is a macrofollicle, but it's just folded over right here. Small flat sheets without overlap, any atypia. Don't confuse these with microfollicles, but they're actually pieces of macrofollicles, fragments of macrofollicles. Microfollicles, they didn't have a great picture in the Bethesda book, but here's a nice microfollicle with a little bit of colloid in there. You can see the three-dimensionality, but the smear I showed you, I think, had a little better representation. So these are the different tests available for further classifying an atypical lesion. So they're particularly useful for stratifying a follicular lesion of undetermined significance, so FLUS. The two that we use here that I've seen most commonly used out in practice are Afirma and ThyroSeq. We offer both here. I know MGH likes to ThyroSeq a lot. What are you guys doing? What's your experience there?
Afirma?
Afirma, yeah.
Okay.
Good morning, this is Christy. I'm the pathology manager, also Cytotech by training. We are now also offering ThyroSeq.
Okay, good. Yeah, so we put both collection vials on our cart when we go for a procedure, and sometimes it may be requested by the surgeon who's doing it. They want one or the other. Oftentimes it may be a radiologist and they don't even know what Afirma or ThyroSeq is. So we just will collect it anyway. So we've made it routine collection. Even though we may not send it, we find that it's better to collect it up front and have it when you need it rather than wish you had collected it when you do and you don't have it. But briefly, Afirma, you'll collect your samples for diagnostic purposes. And once you've established some adequacy that you actually have follicular cells, you don't want to be putting just blood in here. The next pass you can put right into a vial of the Afirma, and we'll freeze that. And then if we have a diagnosis of FLUS or even suspicious for follicular neoplasm, I've found sometimes surgeons will request the Afirma or ThyroSeq just to further help their management of the patient. But what they are they're different gene expression arrays that look at a number of genes. Afirma looks at 142. ThyroSeq looks at 14 genes. It does targeted NGS and also 42 gene fusions. If any of those are positive, it's put into a category of suspicious or benign, and depending on that, they may add BRAF or not. I don't have a whole lot of experience with DiGenX or the Rosetta tests, just haven't used them really at all. But bear in mind, that's something you may get asked to send, so try and collect it up front if you're able to. This, I'm not going to go through every column here, but I'll share the slides after the presentation. But this is a nice breakdown of the method, what is actually how the test is done, its sensitivity, specificity, and importantly, the price. You'll be asked how much these cost. Sometimes the surgeon will ask you, well, let's send it, but how much is it? How much will the patient be charged? And those are all great questions. And it's definitely great to be familiar with your billing department wherever you end up practicing, and getting a good relationship there so you can ask these types of questions so that somebody can help you look into what sort of coverage the patient has and what they may be left with for a deductible or copay on these tests, which you can see are pretty pricey. They're in the multiple $1,000 ranges. This is just one more chart from a different journal here showing the pros and cons of each one. Okay, salivary gland. Did anybody have any questions on thyroid? All right, salivary glands. I have one here. Let me show it to you. Okay, so this is a parotid lesion. So lot of blood. And a sheet of cells here. Right. So first of all, are there any adequacy criteria for salivary gland? So yeah, there is, and I'll show you what that is. So the Bible for the salivary glands is the Milan system, and that was similar to the Bethesda and how they classify salivary gland lesions. One of the authors is Bill Faquin over at MGH. Here's and the adequacy they suggest is 60 cells. So I think you can agree that we've got magnitudes more than 60 here. So this would be an adequate specimen. So you called up to the ENT office. They're aspirating a salivary gland lesion. This comes on the smear. I find that ENT docs, when they do salivary gland lesions, it's very sparse. We get very little material. They're reluctant to go back for additional passes. So you may only get 2 or 3 at most. So this would be really reassuring to see this on the pass, and you'd be able to tell them, yes, this is adequate. You may not know what it is, but it's adequate. Should we try and venture any guesses where this one falls into? What types of cells are these?
I feel these look very malignant to me. This very like cellular, and then these cells, they have like a high NC ratio. I cannot really see the cytology very well, but these cells look very like not benign cells.
Yeah. And just looking at this, these almost look like glass.
Mm-hmm. Yeah. Oh, yeah.
But there's also some smaller cells in here too.
Yeah, it's not a monotonous population. Yes, it's kind of a mixed population.
So,
or like what would I say, pleomorphism? Just which way should we go?
so let me show you this. They also had a needle biopsy done at the same time. So sometimes you may go for a thyroid or a salivary gland or other lesion. It starts off as a cytology, and then they may change the needle type or the gun with whatever they're using, and may wind up with a small core of tissue. What do you do with that? They give you some tissue. What you can do is you can do a touch prep. You can put the core onto a glass slide, air dry, and do a diff quick and tell them, do they have, does it look like it's a cellular lesion? Is it adequate or not? You don't want to try and do a frozen section on it. Try and preserve it, and don't handle it too much with the touch prep. And sometimes these can be really sticky. They're hard to get off the slide. You may end up destroying the architecture by doing that. But this one, pretty well preserved. What do we think of it? Mostly tubules.
Fibrotic stroma.
Yeah, cords of cells. Some inflammation there. But it's interesting that what looked really kind of ugly on the diff quick, the core is a little more, I think, reassuring in the sense that it doesn't have that extreme atypia or mitotic activity, necrosis, things that you might associate with malignancy. What's the most common salivary gland lesion?
Pleomorphic adenoma.
9 is PA, malignant is MEC.
Yep. So the way I approach these, and what's the second most common benign salivary gland lesion?
Watson tumor.
Yep. So the way I go about these is I think, okay, is this a pleomorphic adenoma, or is it a Werthin's tumor, or something else? And that will get you probably 60% of your diagnoses. The other big chunk of diagnoses are going to be non-neoplastic lesions, something that's sialadenitis or an inflammatory process, or the malignancies. And as you said, the number one malignancy is MEC, mucoepidermoid carcinoma. I felt this was a tough case. We actually sent it out for a second opinion. And what do you think it was called?
This does not look like what we say before. This is not PA. This is not a Watson tumor. This is also not MEC. These cells, I mean, we could go to a polymorphous adenocarcinoma, that could be, or this is not classic adenocystic. This is not a cynical carcinoma. So I could not think like other things. Like the only thing I can think about right now is probably polymorphous adenocarcinoma, or. But the other one I can't, because it doesn't look like the classical what we see in the textbook, or yeah.
Yeah, exactly. So this was actually signed out descriptively with a differential diagnosis, and a low-grade lesion was favored. The patient was recommended for excision, and we don't yet have the excision, but and that's okay to be descriptive, put a differential, and recommend the next step. Let me go through. So that was great. You guys did an excellent job. Let me show a few slides on salivary gland.
So was that case, it's considered to be malignant more based on the cellularity?
Yeah,
Cellularity?
yeah, yeah. Right, so as I mentioned, the Bible here that you want to get for salivary gland is the Milan system. Similar to Bethesda, it's broken up into different categories: benign, neoplastic, and non-neoplastic. What's interesting here is that a non-diagnostic diagnosis actually carries a fair risk of malignancy, 25%. So non-diagnostic is not to be taken lightly, nor is non-neoplastic. Less of a chance of being malignant, but still 10%. There's an atypia category like we have in every tumor. Benign, very low chance of malignancy. And then here come the malignant lesions. There's this classification, some salivary gland neoplasm of uncertain malignant potential, suspicious for malignancy, and then malignant. And here's the management. And this is why it's important when you go for a rapid to make sure you get something that's diagnostic. You don't want the patient to have to come back for a repeat procedure. You really want to try and assure that we're going to get something workable, that we can establish some definitive follow-up, either surgery, clinical follow-up, something that we feel comfortable watching or having to take out, rather than some degree of uncertainty. The Milan system of reporting for salivary gland, that's MSRSG, suggests a minimum of 60 cells. What's at stake? The extent of surgery, whether ENT is going to do a radical neck, preserve facial nerve or not, and the extent of surgery is hinging upon this diagnosis. So don't be afraid to ask for more specimens. Make sure you try and come away from the procedure with having something adequate. Some other lesions that might pop up. What if we had that aren't uncommon, that are non-salivary gland neoplasms? So what if we had a whole bunch of lymphocytes that we saw at rapid? What would we want to do? We'd want to send for flow. MALT-type lymphomas, marginal zone lymphomas are common in salivary glands, can be associated. You might have a like a Sjogren's patient, very fibrotic, inflamed salivary gland with a lot of lymphocytes. It's better, just like thyroid, to collect something that you may or may not want to send rather than not have it. So collect something in for flow, and usually, as I told you, we bring some RPMI. We'll collect a specimen there for flow. PTH, had a number of requests recently, both on when I've gone for thyroids and salivary glands, where depending on where they are in the neck, somebody might be considering ectopic parathyroid or a parathyroid cyst. And we've been asked a number of times recently. I don't know if there's been some major guideline that's been released by ENT surgeons, but we've definitely have seen an increase in requisitions for PTH on body fluids and on aspirates, and that definitely is something that can be done. I just threw this in there. You guys can have it after the talk, but the major categories of salivary gland tumors, some of the immunostains you might want to do on the core or the cell block that you've collected, and some of the molecular. So molecular can play a part in salivary gland diagnosis. So bear that in mind. That's also a reason why you might want to collect something in preservatives such that you're able to do some molecular. EUS. Okay, what does EUS, well, before we move on to that, does anybody have any questions with salivary gland? Okay, what does EUS stand for?
I think it's endoscopic ultrasound.
Yeah, exactly. I'd say this is one of the top things we'll get called for after thyroid is an EUS. And who does these?
Usually it's in GI.
Yep, exactly. So it's done in endoscopy. It's good to just review the anatomy of the pancreas because what you'll see, I'll show you how these are done, but what's taken advantage of is the anatomy of the pancreas and how it rests right against the duodenum. So by either going through the duodenum or the stomach, the gastroenterologist is able to biopsy pretty much most of the pancreas. It may not be able to get to the tail, but you'll go to a procedure and they'll say, this is an uncinate process mass, and you might say to yourself, geez, I haven't thought about the uncinate since medical school. Well, that's where it is, the head of the pancreas, neck, body. This is where most of the biopsies are going to come from. Why? Because a patient may come in with the classical scenario is painless jaundice, and that's because there's a lesion here in the head that's pressing on the bile duct or any of the pancreatic ducts and leading to jaundice. How is it done? I was just on one earlier this week and I was so tempted to take a picture in the procedure, but I figured with HIPAA, somebody might get upset. So I'll use one of these Netter drawings here. But basically it's the endoscope is put in down into the stomach, and it's the same scope that they use for doing endoscopy, but what they put on the tip is different. So this is a needle for doing FNAs, and this is done under ultrasound. So the gastroenterologist will guide this down and switch to ultrasound and be able to tell where they are in relationship to the pancreas, major vessels in the area. It's a very vascular region, and sometimes it's difficult to biopsy. You run the risk of hemorrhage, so they're very cognizant of that, and you'll often see them toggling here between flow channels so that they show blood flow and they can see where the needle is and that they're not going to hit a major artery. So oftentimes they'll start with something like this, which is a needle for a FNA. Sometimes they'll do a biopsy. The needle I hear commonly used is this thing called a shark core. And this actually takes a small core of tissue. And it may look like blood clot, a stringy core, but there's actually tissue in there. One of the other major types of needles that you may hear used is Procore. And these are the different gauges. The smaller the gauge number, the larger the bore of the needle. This is a little bit different one. It goes in, and then when they pull it out, it grabs the core of tissue right here, so that when they pull it out at the endoscope, there's some tissue sitting in there that they may slide for you. You have to decide how you want to handle that. Let's go, before we get into that, let's go back to a slide. All right. So here's an EUS, and I did a diff quick on this one. So just at low power, see, we've got some groups. So let's take a look at this group. How would you describe this group?
It's like a solid sheet of cells that are evenly distributed.
Yeah.
Honeycombing.
Yeah.
So those are all buzzwords for something benign. It's uniform sheet of cells, honeycomb, they're kind of flat. On the edge, you can see where they've become a little bit discohesive, but pretty regular. The cytology is very bland. Chromatin is fine. Here's a nice region. So what does this represent? Are we in the pancreas even? One of the pitfalls. Sorry.
Could it be like GI lining?
Yeah. So this could be GI contaminant.
Mucosal.
Remember, we're going through the duodenum or the stomach, so it's good to ask a lot of questions when you're there. Talk to the gastroenterologist. Ask them. First of all, you want to know where the lesion is, where they're going through. Are they going through the duodenum? Is it transgastric? This is probably just GI contaminant. But benign pancreatic ducts can look like that as well. But it's a good contrast for the other group of cells here. How would we describe these?
They're more overlapping.
Yeah.
Junk in honeycomb.
Yeah.
Okay.
Big cells. Is this GI contaminant?
No.
So what is this?
Looks like suspicious for adenocarcinoma.
Yeah, definitely. Here's another group of benign cells, and it's always good to find some single cells too. These are huge cells. So what do we tell the gastroenterologist?
These are very atypical cells. Could we just call malignancy? Or too aggressive?
So when you get called for EUS, it's most often a pancreatic lesion. There are other scenarios where EUS is useful, and what are those? Here's a nice cell that's multinucleated. So you might get called for an EUS where the clinical suspicion is for a GI stromal tumor. So you're looking for GIST, you're looking for spindle cells, you're looking for something that looks like a GI stromal tumor. And that would be usually a stomach lesion, not pancreas. I wish all EUSs were this easy. I chose this one just to go through kind of the main differences between benign and malignant. So I would tell the gastroenterologist at this point, you have adequate cells. I'm very suspicious for malignancy, or I may even tell them it's malignant. They often like to push you. Don't feel you have to commit, but when it's this malignant looking and pretty much diagnostic, it's okay to tell them it's cancer because there's really nothing else this can be. And why do they like to know that? What might they do next?
For surgery or?
No, right during the procedure.
Oh, biopsy.
Yeah, so we might do a biopsy. So this is a FNA. They might do, and I actually have one from this case. So they switched the needle. That was the FNA, and now they switched to the sharp core needle, and this is what I got. Now you can see there's some blood, but then there's small core of tissue. And that's really pretty nice as far as a good specimen. Something we can definitely work with. So what I was trying to get at is they may push you to call it malignant or not because they want to put a stent in. Remember, the patient came in because of obstructive symptoms, so they're going to do an ERCP next. And why does it matter? If you call it malignant, they'll put in a metal stent. A metal stent is more permanent, not going to clot off, whereas they may use a plastic stent if you're favoring benign or you're unsure. And that actually just happened to me earlier this week, and I wasn't sure. I couldn't even commit to that they had adequate cells, and they ended up just putting a plastic stent in, and that was a good thing because the next day, the permanent sections, it was all benign. What are some pitfalls, mass-like lesions in the pancreas that may actually be benign?
Sometimes those sclerosing pancreatitis, they look like can have a mass forming lesion.
Yeah, exactly. You're right. So pancreatitis, autoimmune pancreatitis can sometimes form a mass-like lesion. That's a known pitfall. There are benign tumors. There are cysts. Let's go back to the slides now. Sorry. So this is just an algorithm, whether you're dealing with a cystic lesion or solid, things to look at to tell them whether you've got something adequate or not, and then this is something you can use for working up later the case for diagnosis. These are the cytologic features. So as in thyroid, where nuclear morphology is very important, same thing in the pancreas. So pay close attention because a very well-differentiated adenocarcinoma can be very, very subtle, and it may only just have some loss of the honeycomb architecture, just a little bit of abnormality in the nuclei, whether it's nuclear contour, enlarged, any discohesion. Look for single cells. Single cells are always helpful. Any sort of irregular chromatin pattern, prominent nucleoli, background necrosis, and mitotic figures. And these are some of the features to look for. Here's a literature review that showed the diagnostic utility of these, and these top four are kind of the most common ones that you would think of that we actually actually saw with that last case. You may be asked to, it may turn out to be a cystic lesion, and it may be one of these preneoplastic lesions or neoplastic cystic lesions. So it's often helpful for the gastroenterologist to collect a CEA or an amylase. They may ask you about that. The purpose of that, or the reason, is cystic lesions that have a low CEA are usually non-neoplastic. High CEA used in producing cystic neoplasms. An amylase, low, likely not to be a pseudocyst, so you will often see those ordered when you're signing out a EUS, a pancreas specimen. Look in the chart, see if that was collected. It may not be given to you at the time of the rapid, but they may collect it afterwards and send it to the lab. So look for that. The reason that they do cores often is because more and more we're being asked for doing molecular. We can do it on cell blocks. We validated it, but it's always better to have some tissue, and particularly if you're left with a lesion that you need to work up, it's good to have something in paraffin where you can do some stains. These are just some of the common neoplasms and staining patterns. All right, so the last one here, the last 10 minutes we'll go through. I know we're going quickly, but EBUS, what does EBUS stand for?
Endobronchial ultrasound?
Yeah, so it's just like an EUS, but in this case, they're using a bronchoscope. They're going down the bronchus, and what's the major purpose of an EBUS?
Is it also to rule out malignancy?
Yeah, so it's often used to stage a patient, to assess, or in a patient with a lung mass, you may be able to reach the lung mass if it's central or if it's subbronchial, but EBUS is really useful and used mostly for sampling lymph nodes. And so as such, there's really no accepted criteria. I did find a paper when I was putting this talk together, Annals of Thoracic Surgery, that talked about core size and whether there's cells and macrophages. Nobody really uses that. And then I found this other one that was in the archives and talked about the number of lymphocytes on a slide and how we could use that for adequacy and whether there's pigmented macrophages. In reality, nobody does this. The reason that we like that both thoracic surgeons and pulmonologists like EBUS is you can sample lymph nodes. And these are the lymph nodes that are amenable to sampling by EBUS. And these are the different stations. So you'll hear station 1, 2R, 4R, 2L, 4L, 7, 10R. These are lymph node groups that, if they're positive or not, it really tells a lot about the patient. Patients who have, like for instance, a 2R positive node, they're going to be a patient who's probably not going to have surgery there because it's already metastatic. So EBUS is a way to stage a patient. It may be done instead of a mediastinoscopy, or if the EBUS is unsuccessful, they may go to a mediastinoscopy next. Basically what happens is, much like the EUS, a node is sampled, smeared out. We look at it right on site with a diff quick, check for adequacy. What we're looking for is tumor, or I haven't really seen this much, but I suppose you could see a granuloma. We will often collect something in RPMI. We may want to do flow, we may want to do molecular. We're going to collect some maybe for a cell block that we can process into paraffin, cut, and do some staining. Lymphoma is also a big category of lesions that involve the lymph node of the mediastinum that would come up in a differential for mediastinal adenopathy. So if you've got a lot of lymphocytes, make sure you collect something for flow. Let me, before we go through some of these, let me just show you one. So this is an EVIS, right? This is called right hilar lymph node 12R, so station 12R. We saw that on the map. And this is a diff quick we did right at the procedure. So what's the big things that jump out to you?
Large cohesive clusters.
There's some big groups here. So if we're sampling a lymph node and we see anything other than lymphocytes, right away, you got to be worried about carcinoma, something infiltrative, something metastatic. So how would you describe these? They're cohesive. Can we tell them this is malignant? Some single cells.
Yeah, they're really, really large cells.
Yeah. Probably malignant.
Yeah.
Definitely malignant. Show you what the cell block looked like in this case. So as far as your role there in RAPID is, you tell them you've got diagnostic, you've got the lesional cells present. So the next day, we made this into a cell block, spun it down. What's it look like? And there's a mitotic figure here. Can you put it into non-small cell versus small cell?
Non-small cell. Very squamoid.
Sorry?
Very squamous looking.
Yeah. So this is a squamous cell. And it can be tough sometimes. You may want to do some stains. What stain might you do here to prove it?
CK56?
Yep. CK56, P63, P40 is a really good one, really specific. And what stains should be negative if you're wondering about an adenocarcinoma? Good. Look at TTF.
Like TTF1. Maximum.
Oh yeah, I actually have a stain. So here's P40. So positive, it's a nuclear stain. It's really nice. Let's jump back to the slides and wrap up. Okay. The advantages, limitations. It improves the diagnostic accuracy of mediastinal lymph nodes and staging for patients, improve patient care. It's kind of a lengthy process. You can sometimes get called up and be stuck in the OR for over an hour doing these, and you may come away with a non-diagnostic specimen even after 10 plus passes. And so it can be frustrating, but when it's diagnostic, it's very helpful to the clinician. And that's it. Right on time. Sorry for rushing. If you guys have any questions, you can email me through Alicia. I'll send you the slide set if you want. Does anybody have anything pressing that we can address in a minute or two?
This is Christy again. I actually love your Rose triage form. Is that something you'd be willing to share as well?
Yeah. Yep, I'll send that over.
Yeah, that's awesome. I love it.
All right, great.
Great. Yeah, these are recorded, but it would be great if we could have the PowerPoint since you offered. So thank you so much.
Super. Yeah, I'll send it over.
Okay, sounds good.
Have a good day, everybody.
Thank you.
You too.
Thank you so
Thank you.
Bye.